Welcome to the ATS PCCP joint webinar on lung infection. Please welcome Dr. Gwen Agra.
Good evening for our Philippine colleagues and good morning to our friends in the US. So are you ready to enhance your understanding of preventing pneumonia in mechanically ventilated patients? Most of the time we talk about diagnosis, documentation by radiography, we talk about antibiotic therapy, but we hardly talk about prevention, when in fact that should be our first priority as at the time that the patient enters our ICU. So our learning goals for this session will be to learn from the experts as we delve into effective strategies for VAP prevention, focusing on minimizing mechanical ventilation, encouraging early liberation. We have Philippine reactors and speakers, and as well as US based speakers and reactors. But the topics that will be covered tonight or this morning will be number one, evaluating chlorhexidine versus povidone iodine for oral decontamination. Next is exploring stress ulcer prophylaxis and probiotics as its role in pneumonia prevention. And the third is assessing different endotracheal tube variables like cuff pressure, subglottic suctioning, antimicrobial coatings for pneumonia prevention. And for today, we have three speakers. First is Dr. Barbara Jones from the University of Utah, and I will be the reactor for her talk. Second will be Dr. Jonathan Arquiza, and the reactor will be Dr. Charles de la Cruz. And then the third will be Dr. Ashley Lozier from Yale, and the reactor will be Dr. Rodolfo Pagkatipunan. So we'll start first with the talk of Dr. Jonathan Arquiza, and then followed by Dr. Charles de la Cruz, who will react to his talk.
A very good morning to our colleagues on the other side of the globe and to my colleagues here in the Philippines. Thank you to the organizers for this opportunity to speak. For the next 10 minutes, I have been tasked to review the data on stress ulcer prophylaxis and its association on the incidence of mortality and pneumonia. Then for the last part of this lecture, we will delve into the role of probiotics in critically ill patients. Now, very briefly, the basis for the recommendation to start stress ulcer prophylaxis is based on the incidence of GI bleeding resulting in a longer stay in the ICU. In a review of over 35,000 patients, Saeed presents the incidence of GI bleeding. Most studies, however, indicate a risk of clinically important GI bleeding at 2.5 to 5.9%. Numerous studies show the benefit of stress ulcer prophylaxis on reduction of clinically important bleeding. Here we have a meta-analysis by Barbateskovic showing a reduction on bleeding. A network meta-analysis by Longo in the New England Journal showing a significant reduction in the risk of bleeding, which H2 receptor antagonists and PPI. And two other meta-analysis by Sridharan and another by Reynolds also corroborating the reduction in GI bleeding seen in the other studies. What's interesting, however, is that none of these studies, including the large RCTs, the PEPTIC trial and the SUP ICU trial, showed no effect on mortality with the use of stress ulcer prophylaxis in critically ill patients. Now, in the studies on SUP in critically ill patients that I mentioned, some showed an increase in propensity toward nosocomial infection, while others showed no statistically significant risk. However, they only looked at the incidence of pneumonia as a secondary endpoint. In this large study of 35,000 patients, there is an increased propensity for VAP in those on stress ulcer prophylaxis. Let's investigate this relationship. Unfortunately, there is a paucity of studies on critically ill patients that look at pneumonia risk as a primary outcome, with PPI and placebo as control. Let me present PPI studies that looked at the risk of pneumonia as the primary outcome. This study by Maret Uda is a population-based and nationwide Swedish study conducted from 2005 to 2019, which used a self-controlled case series design and included almost 520,000 patients on PPI. Here they show that there were 198,000, almost 198,000 pneumonia events for patients on PPI. Now, what's interesting in this study is that it looked at the incidence of pneumonia in relation to the duration of PPI use. And what we can observe is that the longer the subjects are on PPI, the greater the incidence of pneumonia. We can see how the pneumonia events increased by 8-fold for patients on PPI for more than 3 months compared to those who stopped after a month of use. This study showed that there was an overall 73% increased risk of pneumonia following PPI use. Therefore, PPI use seems to be associated with an increased risk of pneumonia. Now, there is this interesting meta-analysis which looked at how PPI induced the risk of pneumonia. Unlike the earlier study by Maret Uda, which looked at the incidence of pneumonia in relation to duration of use, this study observed the decreasing incidence of pneumonia the longer the interval from the last intake of the PPI was. So here we see the increased risk of pneumonia for current use, which means that the last intake of PPI was within the previous 30 days. Comparing this with subjects whose last intake of PPI was between 91 days and a year before the index date, we see how the diamond now touches the line of no effect, indicating that the risk of pneumonia decreased after 3 months of stopping the PPI. The previous study showed a positive association between the use of PPI and the risk of pneumonia. The next studies will look at its association in acutely and critically ill patients. We look at this single-center retrospective cohort analysis of all intubated adult surgical patients admitted to the surgical ICU during a 3-year period. Gridlinger looked at VAP occurrence, ventilator days, and ICU days based on the type of SUP given. Now, this is a relatively small study of only 45 VAP patients. Here we see that the incidence of VAP is statistically higher in patients on PPI or H2 receptor blockers compared to sucralfate. However, the risk is the same between the two acid-suppressing medications. We go now to a meta-analysis by Marchina et al., which studied the relationship of one or both groups of acid-suppressing medication or H2RA and PPI and the occurrence of hospital-acquired pneumonia in patients that were admitted for acute ischemic or hemorrhagic stroke. For the PPI group, the relative risk of pneumonia was 2.37. For your H2RA group, the relative risk was lower at 1.73. And looking at the overall risk of pneumonia in the 5 cohort studies, the overall risk of pneumonia was 4.65. The results showed a higher risk of pneumonia for patients receiving PPI and H2RAs. Therefore, they recommend caution in prescribing acid-suppressing medication to patients with a high risk for pneumonia. So what does the data show? Stress ulcer prophylaxis can reduce GI bleeding, but have no mortality benefit. And there seems to be an increase in the risk of pneumonia for patients on acid-suppressing medication. What can we recommend based on this data? First, do not routinely administer stress ulcer prophylaxis in critically ill patients. First, determine the risk of GI bleeding. Then, once patients have been transferred to a lower level of care, reassess the need to continue the stress ulcer prophylaxis, especially when the patient no longer meets the clinical criteria. In the next 3 minutes, we will look at the role of probiotics in the prevention of pneumonia. This is a meta-analysis on probiotics and pneumonia, which included 18 RCTs with 4,893 patients. The results showed that probiotics may reduce the incidence of VAP. Interestingly, the meta-analysis showed that synbiotics were found to be more effective than probiotics for the prevention of nosocomial infections in critically ill adults, and this was corroborated in a meta-analysis by Lee et al., which I will show you next. There was a total of 8,339 patients from 31 RCTs that was included in this meta-analysis. They looked at the administration of TPN, enteral nutrition, probiotics, prebiotics, and synbiotics for VAP prevention. This is the forest plot for each active intervention versus enteral nutrition on secondary outcomes. Look at the forest plot on the top left. Synbiotic supplemental enteral nutrition was more significantly related to decreased incidence of nosocomial infection over pro and prebiotics. Now, in a very recent meta-analysis published in February of this year, very hot off the press, they looked at the association of probiotics versus placebo in the prevention of VAP. The authors concluded that probiotics may be associated with a reduced incidence of VAP. However, the quality of the current evidence is poor. As I end this lecture, I want us to look at very promising data on the use of synbiotics in preventing VAP. This is a triple-blind, placebo-controlled RCT. They evaluated a specific synbiotic. So a synbiotic is a combination of probiotics and prebiotics, and they found that it was associated with a reduction in VAP incidence in patients admitted to the ICU, a reduction in ICU stay, and a delay in the time to develop VAP. So is there a role for probiotics or prebiotics in preventing VAP? Probiotics show promise but have a low quality of evidence. Synbiotics seem to be more promising, though further controlled studies with larger sample sizes are necessary to confirm these effects. Once again, thank you very much to the organizers. I'm available for any question if you have any. Thank you very much.
Thank you very much, Dr. Akiza. And maybe I can have you stand in the podium while we discuss this topic. An excellent presentation. For the people who are in the audience, feel free to put your questions on the chat box. We will be able to take a look and then answer as well. So I think it looks like we have around 6-7 minutes, right, Dr. Akiza, to talk about stress ulcer prophylaxis, and then also the use of probiotics. All of this, I think, relates to our microbiome, right? Which what are the different bacterial compositions that usually reside in our gut and maybe in the lungs, and how, in this case, medications affect the microbiome and the risk for pneumonia. And in this case, people who are in the ICU on the ventilators, specifically, I think, right? There's a lot of studies now on microbiome and try to identify using 16S and all other sequencing techniques, right, to identify different organisms. Some organisms we know their name well because they are typical pathogens. Some are more commensals, like lactobacillus, and some of the more oral commensals in our oral flora. And I guess the idea of using stress ulcer prophylaxis is because of the risk of GI bleeding for patients who are at high risk. And you mentioned patients who are on the ventilators, potentially patients who have coagulopathy and at higher risk for bleeding. And so the studies, as you nicely presented, do show improvement with, in terms of decreased bleeding risk. but in terms of overall mortality, has not really impacted by these drugs, correct? And then the other point is that the use of different types of stress ulcer prophylaxis, there are H2 blockers or receptor antagonists, acid suppressors, and also the proton pump inhibitors. And there's been multiple studies to suggest maybe proton pump inhibitors are a little bit better than H2 blockers. So in practice, at least where I've been practicing in the hospitals, we typically think about using stress ulcer prophylaxis. In fact, it's part of one of the ICU checklists, right? And is to use prophylaxis, and we tend to use PPIs, despite the fact that there's no mortality benefit. And the important point I think that you mentioned is that you have to think about stopping it once the patient do not have that risk anymore coming out of the ventilator or out of the ICU. What's your practice in terms of distress ulcer prophylaxis?
Yeah, thanks for this, Charles. No, so in our country, we do include PPIs in our VAP bundles. I think one of the main issues that we have is that it's often forgotten the purpose of why we started it in the first place. And when patients get better, they get out of the ICU, there's this tendency to continue the PPIs. And sometimes, even when the patients are discharged, they're still on PPIs. And this can sometimes be worrisome because, as I showed you in the data earlier, that the prolonged use of the PPI will actually does have an association with an increased risk of pneumonia later on.
Mhm.
And earlier studies, they were thinking that maybe PPIs could actually decrease aspiration, causing pneumonia. But some studies right now show that this actually increases the risk of affecting the microbiome,
Mhm.
and that initially the acid production in the gut was actually protective for pneumonia rather than a cause of the infection. So basically, it's still part of the VAP bundle, and I think that's why this particular the studies that we discussed are actually quite relevant and
Mhm.
hopefully will inform it to the practice.
Yeah, thank you very much. I think we have similar practice, but I think the sense is that it's potentially may not be as important. We need more studies. Um, and we have patients coming in with a lot of PPIs, right? Either for good reasons with refluxes and peptic ulcer disease. Um, we don't think too much about their higher risk for pneumonia, but certainly I think the data suggests that that's the case. In terms of probiotics, there's with knowledge of a lot of different organisms, um, your study kind of was interesting with the symbiotics, right? That you mentioned versus probiotics, and I think there's a question here from the audience about how do you apply probiotics to our ICU patients locally, and are there specific recommendations that prove this approach? I mean, so far the studies, there's no guideline that recommends it right now, correct? Right, and we haven't used it in terms of probiotics for our critically ill. What's your thoughts in your practice?
Well, yeah, I think the challenge really with probiotics is that there's so many types of probiotics available, and it's really difficult to determine what strain will cause or will help to improve our patient's condition or improve the patient's risk for pneumonia. In fact, one of the studies there was an earlier case report, I think, a few years back, which saw a risk with the use of Lactobacillus plausi, and three patients that were immunocompromised actually developed bacteremia from the use of this probiotics. So there's still not enough evidence really to make a recommendation, and when we do make a recommendation, it'll be difficult to determine what type of probiotics should be recommended. What's really more interesting is the prebiotics, which actually initiate the natural production of the microbiome. So that would actually be more beneficial. And in the last study that I did show was a combination of both prebiotics and probiotics. And that particular combination, um, it it did not mention what country that they use
Mhm.
this particular symbiotic, and it would be interesting to see more studies that use this, given that initial findings seem to be very positive.
Thank you. I think there's a question by a similar person about, do you give pre or and probiotics, or only one of them? I guess it suggests from some of the studies, people are starting to look for potential combinations, right?
That's
In terms of what's the best organisms. Is that right?
That's right. And in the particular study that I mentioned, it actually included prebiotics and 8 strains of probiotics. So it was given in a single capsule. So it was given together.
Mm-hmm. And
Although
then
the
they give,
availability of that locally, no, I don't think it's available in our country at the moment.
right, and I think more studies needs to be done, right, to use these kind of pre, pro,
Absolutely.
or symbiotic organisms and stuff. Um, and I'm wondering if there's any other
Yeah.
question. Do you have any questions,
And
Jonathan?
I think it's also, yeah, it's just important to understand that, not everything is inert, and we do have to look into the safety issues also of giving these probiotics.
Right, because I think a lot of these are not as well regulated, right?
That's
Um,
right.
and um, and so I think more needs to be done, and we still don't know. Like you said, some could not be necessarily inert, right? And how they make it, and quality control, and a lot of these and the data, suggests potential benefit, but they're not as controlled studies as you have described for other larger studies.
I think I just want to mention this because one of the questions that we had, especially while I was in training, was that what would be the optimal time to give the probiotics? Seeing that these are live bacteria,
Mhm,
and usually we give them to patients that are actually on antibiotics already.
mhm.
No, and this is a question that I have not yet seen an answer to in any of the studies.
Right. So if there's no more questions from the audience, maybe we can move on, right? And then we can come back for other questions and the other topics. Thank you very much.
Okay, thank you very much.
So it looks like our next speaker is Dr. Ashley Lozier from Yale, who is going to talk to us uh, about the ventilators, right? Rudy?
Okay, Ashley, maybe we can start.
Hey, Ashley,
Can
you
everybody
muted.
hear me?
No, yes.
Okay. All right. So hi, I'm Ashley Lozier, and I'm going to be talking today a little bit about endotracheal tubes and the prevention of ventilator-associated pneumonia. I have no disclosures. So my learning objectives for today, I'm going to just briefly highlight the anatomy of the endotracheal tube and discuss the role of endotracheal tubes first in the development of ventilator-associated pneumonia. And then I'm going to just quickly reflect back on the VAT bundle practices within the United States, and then highlight some of the technological advances and variables that we have for ET tubes in preventing ventilator-associated pneumonias. I'm just going to start off quickly with highlighting a case, as I'm sure many of you have encountered a similar situation. So a common patient presentation that we have in our ICU is GI bleeding, as where we'll have patients present with massive hematemesis. A lot of times these patients are immediately intubated for airway protection to undergo endoscopy. In the settings of patients who have persistent bleeding, is that they may remain intubated for ongoing airway protection. And sometimes these patients have frequent emesis with coffee ground emesis that require frequent suctioning. Unfortunately, in this case, is like on day 4 of mechanical ventilation, we saw that a patient developed fever, had new chest X-ray findings with a right middle lobe opacity, concerning for a new diagnosis of ventilator-associated pneumonia and aspiration. So quickly, just to review, I think I know at least for us, like we often don't focus on what the actual components of our ET tube have. For the purpose of this talk today, I'm really going to be highlighting the PVC components of the endotracheal tube, also looking at the cuff, which, as we know, is it helps create a seal, as it, and then is it the continuous pressure monitoring, including as it looking at the pilot valve to be able to monitor the pressure. So just a background, as I mentioned, we all know that endotracheal tubes are a natural conduit of a patient's oropharyngeal secretions to get down into their lungs and potentially contribute to the development of pneumonia. A lot of this happens because the secretions tend to settle right onto the cuff. And then over the period of time, as like of a couple of days, we typically have a biofilm that creates by first attachment and then the maturation of the biofilm, and then eventually it's like this, as it seeps down through the crevices of the cuff, and we get dispersion of the biofilm as they can ultimately contributing to a ventilator-associated pneumonia. Within the United States, we have a lot of the places worldwide is like we have ICU bundles. Specifically in the United States, is like we have a strong focus on trying to really decrease the duration of mechanical ventilation. And that's really one of our prime targets to be able to decrease the incidence of VAP. But then it's like we have other modalities, like as we'll mention in today's talk on endotracheal tubes, looking at cuff pressure and subglottic suctioning as well. So as I was mentioning, there are multiple variables of the endotracheal tube that can be used in the prevention of VAPs. I'm going to focus today looking at subglottic secretion drainage, continuous control of cuff pressure. I'm going to look briefly at the cuff shape and materials that are used for the endotracheal tube, and then looking at the prevention of and removal of biofilms on the endotracheal tube. So first, looking at subglottic secretion drainage. So this is just a diagram looking at what a subglottic secretion drainage device would be. But this is looking at the removal of oropharyngeal secretions pooled above the endotracheal tube cuff. And this is known to show or reduce the risk of aspiration and VAP. So it's a specifically designed endotracheal tube that has a dorsal lumen opening for subglottic space suction. But there are a lot of factors that can affect the efficacy of how well this device can work. A lot of that, as you can imagine, depends on the viscosity of the secretion. So if they're too thick, the suction may ultimately not work. It's similar to if we're using a bronchoscopy and trying to remove secretions as well. Whether or not we're doing intermittent versus continuous suction of these subglottic secretions. And then also just the positioning of the patient, their body habitus, along with the endotracheal tube positioning itself. If you can imagine, it's like the opening space for the suction can get obstructed quite easily, so it may not be as efficacious at that time. And that's just highlighting kind of where this subglottic suction device would be above the cuff. So with regards to the efficacy, there is evidence to suggest that subglottic secretion drainage can reduce VAP incidence and mortality. This is a meta-analysis from 2019 looking at the forest plots of multiple studies that have used subglottic secretion drainage. And we do see towards the left side of the forest plot that the incidence of VAP tends to be reduced with the use of these devices, along with the mortality. So next off, I'm going to look at continuous cuff pressure monitoring. So as we all know, the cuff is an inflated device, and typically we target between 20 and 30 millimeters of mercury for pressure to help create a seal to prevent seepage of the oropharyngeal secretions down into the lower respiratory tract. And cuff pressure is really essential to be able to manage this and also allow proper mechanical ventilation. We have multiple modalities that can allow for monitoring the pressure. There are the automated devices, as like with that can be connected up to your monitors and screens to be able to have continuous second-to-second monitoring. But also, as like more commonly used, is the handheld manometer devices. There are many studies looking at intermittent versus continuous monitoring of the cuff pressure. Intermittent can be defined as looking at every 8 hours. Many of the studies have looked at, along with when it's been clinically indicated. So if people notice that patients are not getting, if patients hear an audible leak, or if patients are no longer getting the targeted mechanical ventilator volumes, that can trigger a clinical indication. And then there's also the continuous. So as I mentioned, those that are automated and going to continuous monitoring devices on a second-to-second. There are studies that have been comparing the two as like of intermittent versus continuous. Perhaps one of the most notable studies that really favored the use of continuous versus intermittent, which in this case was looking at an intermittent of every 8 hours, was this study in critical care in 2014 that showed that continuous cuff pressure monitoring in comparison to intermittent had more days free of ventilator-associated pneumonia. Of note, in this study, they did also use the subglottic secretion drainage systems in addition to the continuous cuff pressure monitoring. But then another more recent study, which was in CID in 2022, looked at continuous versus intermittent cuff pressure monitoring as well, and they ultimately showed no difference. So I think at this point in time, knowing that having monitored cuff pressures, whether it's intermittent or continuous, remains important. The frequency of monitoring remains to be determined, but at this point in time, we should all be monitoring our cuff pressures just to make sure that we're protecting our patient's lower respiratory tract from the aspiration of or micro aspirations of secretions. So next, I wanted to look at the endotracheal cuff shape and materials. So the most common application of the cuff is if we all know that we have to inflate the cuff, and then typically to help prevent the creation of folds as the endotracheal tube is going in, we will sometimes use a lubricant just to help create a more appropriate seal as it's going down into the endotracheal area. And this can help improve the cuff sealing and help prevent the leakage of biofilms and microaspirations. There are multiple studies that have looked at different shapes of the endotracheal tube cuff. Perhaps the most well-studied is a tapered cuff, as you can see here on option A. And that was shown to have better sealing in animal models. But the human studies have really failed to show the same benefit in preventing VAP. So it does remain important, but the studies still need to determine what is the best shape in our human patients at this point in time. As we know, most of our endotracheal tubes are made of polyvinyl chloride or PVC. There have been studies looking at different materials such as polyurethane. The polyurethane cuffs have thought to be a little bit more flexible and to have a little bit less tracheal injury. And suspected to have less microaspiration, although these studies looking at polyurethane cuffs really have failed to show a reduction in VAP at this time, but the studies are ongoing. So next, I think, as an important topic is looking at how do we address the formation of biofilms within our endotracheal tubes. Biofilms can form quickly as following intubation. About 70% or so of our patients who have VAPs typically will have the same pathogen isolated on their endotracheal biofilm that's been in their tracheal secretions or in their lower respiratory cultures. So I think focusing on preventing biofilms is going to go a long way in helping protect our patients from the development of VAP. So there are some modalities that we can look at for the prevention of biofilm formation, including antiseptic impregnated endotracheal tubes, along with the alternative, which would be to remove the biofilm once it's already there. So that is more of a mechanical modality, including things like closed suction systems, along with mucus shaver devices or mucus slurpers. So looking at biofilm formation, the prevention can include, as I mentioned, antibacterial coatings of the endotracheal tube. Perhaps the best study is the best studied or described has been silver-coated endotracheal tubes, and this typically includes a internal lining of the endotracheal tube that has a coating of silver, and that's largely because of the antibacterial and non-toxic products of the silver is like when it's used in small amounts. Alternatively, and then as you can see here, is like with silver, is like we have the antibacterial properties, so it can attack the biofilm itself and also contaminate its secretions around it to hopefully help prevent the formation overall of the biofilm. Alternatively, there are PVC alterations that you can have in the endotracheal tubes. So there's been another focus looking at the creation of micro and nano modified endotracheal tubes. This is an image kind of looking at the creation of grooves and kind of ridging around some of the endotracheal tubes to help as it decrease some of the adherence of the biofilms as well. There are a lot of studies that have been looking at kind of electron microscopy is showing the reduction of biofilms from Staph aureus along with Pseudomonas aeruginosa, and is it really looking at how is it some of these modified PVC surfaces can actually reduce the adherence of the bacteria. So next, as I mentioned, is it the silver-coated endotracheal tubes. I wanted to just focus a little bit more on how these are perhaps the most well-studied of the prevention of biofilms. There was a study in JAMA in 2008, which looked at the silver coating of the interior surface of the endotracheal tubes. This was by the NASCENT group, which is the North American Silver-Coated Endotracheal Tubes Study Group. And they showed, looking at this Kaplan-Meier curve, a reduction in VAP occurred with the use of a silver-coated tube. So the silver-coated tube is on the bottom line, and then the control tubes are on the top line. So a reduction in VAP, but ultimately this study failed to show any reductions in ICU mortality, length of ventilation, or length of ICU stay. And then it's like a more recent study from about a year and a half ago was looking at a similar type of endotracheal tube, but this was called noble metal coating. And this was a noble metal alloy with components of gold, silver, and palladium that were firmly attached to the ET tube surface. And again, this study had promising findings to show that there was a delay in the development of VAP in those who had the noble metal alloy containing endotracheal tubes in comparison to those with a control tube. So those are really promising findings to suggest that an endotracheal tube can actually be used in the prevention of biofilm creation. I think a lot of what we need to consider is when to use these types of ET tubes and whether or not they're readily available given the cost of these tubes as well. So it is something that to be looking for as more studies are done to identify the appropriate populations. And then lastly, I just wanted to highlight some of the potential mechanical devices that we can use to eliminate biofilm. So I thought this was a neat device, which is an internal mucus shaver. It's a device that actually goes through your endotracheal tube. It has a little balloon that gets inflated, and essentially you inflate the balloon and you pull it back to scrape the inside of the endotracheal tube to help remove the biofilm. Similarly, and probably more routinely available are closed suction systems. I know this is something that we use routinely in a lot of our intensive care units. And the thought is that a closed suction system can help prevent VAP just by making sure that the system remains closed and doesn't open up to any contamination. And this just allows suction of the internal components of the endotracheal tube and down below as well. So just in conclusion, we know that endotracheal tubes can promote and contribute to VAP development through the development of their biofilms. VAP bundles do exist to help prevent the development of ventilator-associated pneumonias. And there are multiple endotracheal tube strategies that exist to help prevent VAPs. But additional studies are needed to determine the best strategies for our patients. Thank you.
Okay. Thank you, Ashley, Dr. Losier, for your excellent lecture, as always. But I uh, endotracheal tubes are always blamed for the occurrences of ventilator-associated pneumonia. We have done a lot of studies. We've done studies on changing tubes every now and then, including the ventilator tubings. But how come at this point, with the amount of evidence that we have, we still cannot point to a particular strategy that can really prevent ventilator-associated pneumonia? For example, the development of antimicrobial linings in the endotracheal tube, the protection will last only for 7 days. Then after that, it doesn't help at all. And here in our practice here in the Philippines, we don't have much of that except for the changes in the shape of the endotracheal cuffs. We do have closed tracheal suctioning system, but not all of us are in agreement in using those because here in our center, we are encountering more inspissated mucus because of the inability to or difficulty in using the closed suctioning system. So some of us revert to the open suction system, especially if the endotracheal tube diameter is a little bit small. Can you comment on that?
So I think it right now is like our routine practice is generally to use the closed suction devices. They are obviously fraught with issues, especially if you have viscous secretions where they have difficulty clearing with the use of those devices. But you're right, is that there is not a great standard approach as to what is the best practice in suctioning devices, along with what is the best endotracheal tube to use at this point. I think we all have the same concerns that with these coated endotracheal tubes, the efficacy or the duration of their effects is like really gets back to what the root cause is, and our main goal of trying to extubate these patients in a more timely manner to hopefully allow them to have the appropriate glottic closure to prevent microaspirations and pneumonias at large. But yeah, I don't think we have a great grasp on what is the best ET tube to use at this point in time. I think there's lots of studies that are ongoing, and I think there's promising factors to suggest that these might be beneficial in the short term. And I know, like, based off of our VAP prevention guidelines right now, the use of these subglottic devices or subglottic suction devices, along with kind of the question of different types of ET tubes, really depends on if you think a patient's going to be intubated for greater than 48 hours at this point in time. And then the hopes is that like over that kind of initial period of intubation that you can prevent the development of that. But what happens at the longer period of time when somebody's greater than 7 days, I think the jury's still out.
Yeah. Yeah. So there's a lot of things going on, but still we cannot point our finger on a particular thing that we can really say that it helps prevent ventilator-associated pneumonia. Although we do have the capacity to measure cuff pressure, is there a recommended way? Because what we do in clinical practice is measure it every day when we make rounds, just to make sure that the cuff pressure is okay. But on how long do we measure it and how often do we do it? There's no specific rule on that, do you think?
Yeah, I think so. I think that's why I was highlighting kind of those two main studies. Is that the most recent study really showed in the CID paper that there really was no difference in continuous cuff pressure monitoring in comparison to intermittent. The definition of intermittent is widely varied. So in practice, a lot of the studies looked at every 8 hours, but as again, I mentioned, some studies looking at intermittent being as when clinically indicated. So sometimes that was once a shift, once a day, or just when there was a noted change in the ventilator that would warrant the monitoring of the cuff. So I think just having the awareness and kind of the knowledge to make sure that you are checking to make sure that the cuff is not slowly becoming deflated and maintaining the appropriate pressures is really the mainstay of what each ICU should be doing. And hopefully, as in kind of upcoming VAP prevention guidelines, we might see a little bit more data on the frequency needed for cuff pressure monitoring, just to give everybody a routine standard practice.
Yeah, even the amount of pressure that we determine as an adequate cuff pressure is also in question. There's a question here, based on your experience, what is or are the more effective endotracheal tube strategies to prevent VAP? But as we are discussing, it's on case-to-case basis.
Yeah, I think so. And I know like our institution has studies going on looking at subglottic suction as well as trying to in the prevention of VAP. But I think a lot of this is still out, and it is a case-by-case basis. And I think the biggest thing we know is obviously the larger preventative measure of just trying to get our patients extubated earlier, or hopefully not even intubated in the first place.
How about the diameter of endotracheal tube that you would need to insert to a particular patient? Is there a standard way of predicting which one is appropriate? Is it a larger endotracheal tube or a smaller one? Because now we're considering, aside from initiating the mechanical ventilation, you are already thinking about weaning the patient eventually from the mechanical ventilator. And if you put in an inadequate size or inappropriate size, that could be a factor during the weaning period from the mechanical ventilator. Can you comment on that, on the endotracheal tube size? How do you predict which one to use?
I think at this point, in terms of predicting which endotracheal tube size to use, we're still mainly just going based off the size of the patient to help us predict whether or not we need to use anything between like a 6.0 to an 8.0 tube, and whether or not we're planning on needing to do any interventions. Ideally, we try to use the smaller ET tube as we can, just to help us limit any of the endotracheal trauma that we could have within the airways. But other than that, that's kind of our main predictive factors at this time point.
So there's another question from Dr. Kitsius. Great lecture, Ashley. The subglottic ETT drainage of endotracheal tubes appear to have consistent and protective effect by meta-analysis. Any thoughts on why uptake of such endotracheal tubes in practice has been limited, maybe outside of the price? What do you think are the other hindrances for acceptance?
I think that's the main factors right now. Obviously, as any of these endotracheal tubes, until the meta-analysis really help give us more supportive data, the price is always going to be a factor to adopt these more widespread in practice. It seems to me that some of these devices are becoming a little bit more widespreadly available. I know I personally have not seen anything or seen all of these devices, and I would say that we have a pretty high resource rate that we are often using a lot of these new components. But I think until they're more widely adapted based off meta-analyses, we'll start seeing them at that point within our routine practice.
So he has a follow-up question. Is VAP prevention in the US a hard endpoint to convince hospital administration to invest on the need for different equipments? It's the same here in the Philippines.
I would think that it's a relatively straightforward straightforward endpoint for hospital administrations, but I'm not involved in a lot of those discussions at this point, so I can't necessarily say is it kind of from the larger aspects.
Yeah. Do you have any experience on the mucus escalator things that you use to prevent the mucus from accumulating inside the endotracheal tube?
So no, I haven't seen those in routine practice. I was really intrigued by it when I was reading them, just because the concept seems really fascinating and very straightforward, as like to think about mechanical reduction. It's kind of like when I think about airway clearance from a mucus reduction in patients just who are not intubated. The studies largely have been on animal studies, but in the respiratory care journals, there is some studies looking at these in humans, as suggesting that you might have some effect at decreasing biofilm amount and kind of sputum within the endotracheal tube.
So we don't have any experience on the continuous pressure monitors here, but we do have heat and moisture exchangers here in the Philippines. So some do not want it, some do, but the analysis of patients with more than 7 days of mechanical ventilation, there's no difference if heat and moisture exchangers are used compared to the standard ones.
So I didn't get into the details on circuit and heat and moisture exchangers in this talk specifically, but yeah, there's a lot of debate kind of on that as well. I think it's like we do variably use them as well in the United States, but ultimately there is no final inputs on that right now.
Yeah. So there's another question regarding the use of airway clearance therapy machine in preventing VAP. Do you have any experience on that, as we have discussed before?
So I didn't, so in preventing VAP, I actually haven't looked that up specifically in preventing VAP. I mostly deal with that on the outpatient side, as again on the inpatient side of preventing pneumonias and preventing bronchiectasis exacerbations. I think that's something that definitely could be looked at as specifically in patients with structural airways disease, whether or not we might be able to help also decrease the incidence of VAP if we can actually get their secretions better managed in the lower respiratory settings as well.
And I don't think the use of mucolytics helps in the prevention of the accumulation of biofilms in the endotracheal tube, right?
Not that I saw, as when I was going through my literature search. There's a lot of studies that have looked at the decontamination of endotracheal tubes. Perhaps the best studied is gentamicin within the endotracheal tube, but not specifically with regards to mucolytics at reducing the biofilm creation.
Okay. So I think are we ready with the next speaker? Okay. Thank you, Ashley. Nice seeing you again. Hope to see you in ATS.
Our next speaker is Dr. Barbara Jones from Utah. I would like to thank all the participants because we are in different time zones, but we managed to set apart some time to attend and interact with each other. Dr. Barbara, are you ready?
Yes, thank you so much. And I apologize for a small miscommunication where I thought this was tomorrow. So one of my slides I am missing, but I'm going to share with you what I've got, and I look forward to talking to you about this. Thank you. Can you see my screen?
Yes.
Great. Okay. Let's go back to the top. Okay, great. And so I didn't get a chance to I was going to talk to my ICU team today about how we implement things in Salt Lake City. I'm part of the VA, and so my ICU setting is one of the veterans hospitals. And we have a very standardized approach to prevention. And our nurses are very engaged in our prevention of ventilator-associated pneumonia. Just kind of brief outline, talking a little bit about some of the changes in our prevention guidelines from 2014 to 2022 around oral care, and what the evidence was that drove some of those changes. And then I think we'll just discuss some bottom lines. So one analogy that I use when I'm working with mechanically ventilated patients is the mountain. Before I was training for pulmonary medicine, I actually was a doctor in the Himalayas for a while. And this is a very risky situation when you're above, let's say on Everest, if you're trying to climb Everest, you're above Camp 4. And I think of, and I talk to families with mechanically ventilated patients about it kind of being like above Camp 4. So basically, the longer you are exposed to that really austere mountain environment, the more likely something is going to happen. You're going to have what the climbers say, shenanigans. And when you're on mechanical ventilation, that is kind of the same thing. And so one general principle is you just try to get off the mountain as fast as possible. And you try to efficiently not make any mistakes while you're on that mountain. But really, it is a matter of exposure. That's probably the biggest, just the amount of time you are on the ventilator. Setbacks are anticipated. So with the oral care prevention, one of the guidelines, this is our 2020 14 guidelines that was led by Mike Klompus, who's a colleague of mine in research, and he incorporated a lot of the kind of the essential approaches. I'm sure you may have already had a talk about with this, and from the 2014 guidelines, we developed a lot of bundles, and it was really key to have this bundled care where people could easily access these really key 5 principles. And oral care was in there with chlorhexidine because there was a reasonable amount of evidence that that could actually reduce VAP. But then in 2022, these guidelines have changed. So in 2022, it's still an essential practice to do oral care, but with tooth brushing. But there was a little bit of evidence that was maybe concerning around the chlorhexidine component of that. And so that has changed to oral care with toothbrushing, but without chlorhexidine. And here's one challenge to generating evidence in VAP is that VAP is a very difficult complication to define. It can be very subjective, and the interventions are very difficult to blind. People know when they get their teeth brushed. So it's difficult to blind the study participants to, both the intervention and the outcome is often pretty subjective. So here's the evidence that supported oral care in a Cochrane review. This is a really nice scoping, systematic review of the evidence around oral care. And you can see on the left there kind of evidence summary of the impact of chlorhexidine versus placebo and usual care. And so this is oral care twice a day with chlorhexidine and just the compared to usual care, which often wasn't nothing. And the outcome was incidence of VAP. And you can see that for incidence of VAP, it seemed to have a suggestion of benefit. The little diamonds there are all a tiny bit to the left. But then on the right, when you use outcomes that are a little bit less subjective, so sorry, I'm seeing the forest plot on the right is mortality. And so you would expect that if you had reduced VAP, you would also see a signal for reducing mortality, given that about 10%, there's an attributable mortality of 10% in VAP in mechanically ventilated patients. You would expect the mortality to improve as well, but it really was, no improvement, no impact on mortality for oral care. And this is oral care with chlorhexidine compared to placebo, which is, usually some oral care, but then when we looked a little bit at the let me see, I apologize, I'm being. Yes, so then when you compared those regimens of oral care versus other agents, there actually didn't seem to be a big benefit, kind of on the right there. And then there was an additional, this is a nice meta-analysis of other clinical trials with oral care with chlorhexidine versus not. And one concern was raised that actually chlorhexidine twice a day could actually be slightly harmful. And so this is a slight increase in mortality compared to oral care without regimens without chlorhexidine. And so that led to our current guideline, where it does seem that oral care may have some benefit, but we're actually not suggesting the chlorhexidine anymore. So the bottom line is basically that, you know, the impact of oral care on VAP is actually a pretty difficult thing to establish. So the evidence surrounding that intervention is actually a little bit shaky. There's a subjectivity of VAP. We have unblinded studies. And so we don't actually have any clear evidence that it supports a reduction in things like mortality, ventilator days. But chlorhexidine actually may, you know, there was a little bit of a signal toward harm, but oral care is listed as an essential practice, and that's due to it's really low risk and possible benefit. And I actually work with a lot of nurse researchers and nurse initiative folks with HAP prevention for non-ventilated patients. And really oral care is something that it can really bring back a patient's source of dignity, when they're not able to, take care of their mouth on their own. This is something that it may actually really improve your chances of getting off of the ventilator, but it also really makes it's for comfort, and it's a kind of an important thing to do. So we also think of that as for the whole patient. But most important is probably really trying to get that patient off the mountain. And I'm sure you've discussed that a lot too, but one of the other key essential things is to try to avoid intubation, and then really trying to get patients off of the ventilator. And I'm sure you discussed this, but this is one thing that, the ICU liberation bundle is another really trying to really simplify some of these complex interventions that really do make a huge difference. And I think that's all I've got. So apologies for being a little bit, had a couple ideas about implementation, but
thank you so much, Barbara, for sharing your experience and your thoroughly researched talk. But going through all the studies, there are actually a lot of differences in terms of administering chlorhexidine, like from a 0.12 to 2% concentration. Is it in a gel form or solution form? Do you use a brush, or do you use a cotton ball, or whatever? And even the frequency, some of the studies vary from 2 times to 4 times a day. So I guess those factors also matter in terms of their results. And then there are some studies that even mention those who underwent cardiac surgery had better benefit versus those who did not undergo cardiac surgery. And some of the adverse drug reactions that were mentioned were irritation of oral mucosa and question mark aspiration of chlorhexidine. That's what they were quite worried about. That they were saying that it may cause ARDS, but some papers argued that it wasn't really documented that chlorhexidine caused ARDS. So it's really still, I think, a gray area.
Yes,
that's why
definitely.
you mentioned that there are changes in the guideline, but then again, normally even in non-intubated patients, we emphasize oral hygiene because they can aspirate the bacteria, and some of them may actually form biofilms. That was also mentioned by Ashley. So now the question is, if in your center, did you really eliminate chlorhexidine altogether?
Yeah. And that's actually a very interesting, in a way, kind of social de-adoption. We actually have a lot of nurses who believe pretty strongly in chlorhexidine. It's very efficient. And it is part of our kind of culture here in the ICU. So we actually try to emphasize that it's probably just not a good thing to do more than twice a day. And so that was definitely, as you mentioned, one of the biggest signals with chlorhexidine was the frequency that was greater than 2 times a day. So that was definitely, but I think the guidelines are really trying to emphasize that it really is probably the oral care component and probably not the chlorhexidine component, and to be careful, with too much chlorhexidine. And I think that you're in non-ventilated patients, it really is something that is important to routinize. And the mechanism is also another, it makes sense. I think it kind of reveals that we don't actually understand the pathogenesis of pneumonia very well, though. And we actually don't have a very clear signal on, whether oral care is really preventing pneumonia in non-ventilated patients. So that's another place where it's very difficult to find objective data that really supports that evidence. We see reduction in rates of HAP, but it is that is a very difficult thing to characterize. And since these are unblinded studies, it's really hard to establish that there's a clear evidence to support that. But as it's sort of a source of dignity. It's a patient comfort, experience thing too. So that's something to keep in mind.
Yeah. Okay. What about other agents? So there are some studies that mentioned povidone iodine. There were some studies that even used hydrogen peroxide, even Listerine. Locally, some centers use hexetidine or Bactidol, but I
Oh,
haven't
interesting.
seen a lot of studies regarding that. I've tried searching everywhere, but very little evidence whatsoever, especially in intubated patients. So I think the centers here locally should reconsider trying to review some evidence because I didn't find any.
Oh, that's really interesting. Yeah, and I'm not familiar with the evidence that's comparing the iodine or other agents. So what do you guys usually use? Are you usually using chlorhexidine?
It's still chlorhexidine.
Yeah.
There are 2 recent studies done in Asia, one in China and one in Indonesia, comparing povidone iodine and chlorhexidine 0.2%.
Yeah.
Both of them actually said there's almost the same protective effect. The one in China said there's almost the same protective effect, but subjectively patients preferred povidone iodine. And then the other one done in Indonesia, they said 0.2% of chlorhexidine mouthwash was had a lesser incidence of early VAP, but not statistically significant. So basically still non-conclusive.
Yeah, that's interesting. And how difficult is it for you guys to implement that? Are people using this similar kind of bundles, putting multiple VAP prevention kind of components into a nursing task list? Is that pretty routinized in your workflow, or?
Yeah, in our center, it's oral care is part of the routine, but there are some centers that they just use a swab, not necessarily impregnated with some chemical, and then the other parts of the bundle that were discussed earlier, the tracheal cough monitoring. Some of our ventilators have built-in cough monitors, so we do that too. And then, but regarding the tube, I don't think we also have a choice because it's like an admin decision to purchase which kind of tube, endotracheal tube that there is.
No.
So for your there are even articles that say you brush your patients with chlorhexidine solution, but some would just say just brushing. So some would use saline, but do you use saline or water? I'm just imagining if I'm the patient, it's gonna be quite salty if they use saline.
Yeah, yeah. And this, I actually have to talk to my nurses today about this in our ICU. I believe they still do the chlorhexidine. They just don't do it they had been doing it 4 times a day, and now they do it 2 times a day. But it is a pretty efficient and pretty well tolerated chemical. But I have seen other settings that use saline. And then in the non-ventilated patients, they use toothpaste.
Yeah, that's true. Okay.
Just make
And
note of
and
that.
some patients would have some dental caries, or they don't have teeth, so that would also be a factor in terms of outcome.
Yes, that's actually true. And that's a kind of a growing, field, and hopefully we'll learn a lot more about how to prevent pneumonia in the non-ventilated patient. That's, a slightly different mechanism. I think we don't understand it very well. Oral care is one, hospital, nursing task that we can potentially, something that we can do to prevent that. But there are all sorts of additional hospital exposures that are probably setting patients up for that are, warrant a lot of study, but we'll see.
Yeah, thank you. Are there any questions or comments from the floor, or from online, from Zoom, and here in the auditorium? Charles, do you have anything to add?
No, I think, hi, Barbara. I mean, these are kind of important sort of highlights, the role of microbiome in the pathogenesis of pneumonia, right? And so all the topics that we heard today is like, where are the bugs and how to get rid of the bugs and how the bugs change and how did the bugs stick to the ET tube, and so I think there's a lot to be learned. And then certainly I think there's some studies to suggest that even the role of anaerobic organisms, right, oral flora and etiology pneumonia has been challenged, right? And so as we try to oral decontaminate or even gut decontaminate, I think those studies have been sort of in a mixed range, and I think I've seen facilities transitioning to toothbrush use, right? And not as much as chlorhexidine. And I agree. I think some of these studies, when they first come out, looks really nice. And once you have more general use in the bigger number of people, studies and meta-analysis suggest that the signal starts to get weaker. And so, and I think I agree. I think it's an active area that's kind of interesting. And I think we certainly want to prevent pneumonia. I guess my question is, I think we heard about probiotics, we heard about using chlorhexidine, and so it's almost like we're trying to add organisms, but then using things like chlorhexidine to get rid of organisms, right? And so it's kind of intuitive, doesn't it, Barbara?
Right. And that is definitely something that's so exciting to see change, because, prior to a lot of the research in the microbiome, we used to think that the lungs were a sterile compartment, right? Below the vocal cords was a sterile space. So of course, a mechanically ventilated patient, the pathogenesis of pneumonia there is, one where infection only happens if you have an invasion of a foreign bacteria that's then invading this sterile space. And then that makes the solution very simple, which is kill the bacteria, but now we know that we're actually colonized, with lots of commensal bacteria that have this very poorly understood relationship with the human, organism cells. And that's very complex and poorly understood. And it's more like an ecosystem model, right? So you're kind of talking about now our model of pneumonia isn't invasion. It's really just overgrowth of oftentimes existing, organisms. And the trick there is that it's not so simple. You don't just kill the organism to regain, homeostasis. You actually have to, kind of think of it from a ecology, standpoint. And so, yes, chlorhexidine is kind of a great example of this, because we used to just think you'd kill the bacteria and that we're invading right from the mouth. But it's a lot more complicated than that. Maybe you don't actually, maybe you want to retain the healthy ecosystem and make sure that you maintain balance. And so avoiding dysbiosis, and dysbiosis is kind of one of the new terms, is kind of more, and then, the tissue host response to that, of course, is another huge element of that. And, that's becoming a lot more complex, and it's going to be really exciting to see that kind of unpack over the next few years.
Yeah, and I think in clinical practice, in terms of how we take care of our patients, to see, well, how does anything we do or not do changes that ecosystem, right? And so it's not like black and white sometimes.
Yeah, very much so. Yeah.
Yeah, okay. I don't think there are any other questions from the floor. So I think overall, with all the topics that we discussed, we didn't have a really strong, definite answer. It sort of makes us more reflective of what the things that we do, why we do it, which subset of patients will benefit. So I think we need to be more mindful about doing these rather than routinely just covering everybody with a certain bundle. So I think some of the conditional indications that were stated in the guidelines compared to routinely blanket, it's a blanket statement that covering all of these patients sort of reminds us to be more careful and to individualize our protocols also. I think it's about time that we end this because we're beyond 1 hour. But before we end, I would like to invite everyone, those from the Philippines, we're excited to meet you in person, our colleagues from ATS. So it's good to interact online, but we would also want to see each other in person. So Jadir, do you have a poster of the ATS meeting this May in San Diego? There. So I hope you can, if you have time, I think we have a lot of Filipino delegates attending almost every year, and PCCP is also already tied officially with ATS. And we're so happy that we can do this. I hope this is not the last time that we have this great interactive webinar. And I would like to thank all our panelists, our speakers, for their time and their effort to be here and to share their expertise to the audience. Charles, would you like to say something in behalf of ATS? Oh, yeah. Charles, would you like to say something in behalf of ATS?
Oh, yes. Thank you very much, Gwen and Rudy and all the participants. I would like to thank Ashley, Jonathan, and Barbara for their wonderful talks. And I think the format of this presentation with reactors, I think, is really kind of unique and really foster a lot of discussions, which I think I personally enjoyed to really delve into the topic more. I hope we have more of these in the future. And this was almost a year in preparation, right, Gwen? And so I think ATS has a venue mechanisms to submit something like this. And we appreciate their help and our colleagues in PCCP and to co-host this. And so thank you very much for your attendance.
Okay, good night, everyone. Good morning to you.
Good night, everyone.
See you soon. Dr. De La Cruz will be here in May for the Philippine College of Physicians. See you, Charles. Bye.
Okay.